It's time to start our webinar tonight. Randy?
Thank you. Good evening. I'm Randy Reiser. I'm the 2020 president of the Medical Association of Atlanta, and I'd like to welcome all of you to this joint presentation of Medical Association of Atlanta and Cobb County Medical Society, surviving and even thriving during COVID-19. This seminar tonight has been approved for up to 2 hours of CME credit, and credits will follow your registration. Our panelists have no conflicts of interest to disclose. You know, even before 2020 and COVID-19, physician resilience and physician well-being has been a major concern, and it's been something that's been growing in concern over several years. And our medical association has thought to include that in our program for this year, and this was even before COVID. But the situation now with what's happened recently is even more acute, and really brings the need of physician to talk about physician wellness and physician resilience. We have 3 panelists tonight, all of whom are experts in this field. And I want to thank, first of all, our program team of the Medical Association of Atlanta that's headed by our President-elect, Ali Rahimi, for all the work that they've done in assembling and producing this seminar tonight. Our first panelist is Florence LaCroix. Florence is an anesthesiologist who practiced for 37 years in operating room anesthesia and now works at Northside Outpatient Imaging Centers. In recent years, she's subspecialized in health economics, and her research focus is on medical liability, patient safety, and healthcare provider burnout. Florence is an adjunct professor in the Andrew Young School of Policy Studies at the Georgia State University. And most importantly, she serves as a director of the Medical Association of Atlanta, and she was instrumental in working with our program team to produce tonight's program. Florence?
Thanks, Randy. You know, it is an honor to present to this audience, this great audience, who want to take excellent care of their patients and help their colleagues who are maybe suffering in the pandemic. I'm thrilled to be a panel member along with Dr. Hickson and Dr. Olsons, who are rock stars in this. David Waldrop and Joanne Thurston, thank you for organizing this. The title of this seminar, Surviving and Even Thriving During the Pandemic, was suggested by my husband. The first month of the pandemic, we went up to our mountain house. There was no one around 24/7. I thought somebody was going to die. Hopefully it wouldn't be me. But fortunately, we adapted and developed new system to cope with this new environment. And 2 weeks ago, I'll have you know that he said, Lawrence, I like having you home with me. So there's hope. Now, most of you know that physician and nurse burnout was a problem before the pandemic. Surveys showed that almost 50% of physicians and nurses had at least one symptom of burnout. Experts say that due to the new stresses of the pandemic, even more professionals will experience mental anguish and burnout. This has become a public health crisis. Nurses and physicians are like the proverbial canary in the coal mine. Although it is compassionate and necessary to take care of the canary, it's futile if all we do is put them back in the toxic mine. We need to get fresh air in the toxic mine. I was a practicing anesthesiologist for 37 years. A friend who is a psychiatrist on faculty at UCLA Medical Center told me that as a female anesthesiologist, I was in the subgroup of physicians that had the highest suicide rate, and that is high. And that did not surprise me at all. Because over the last 10 years, my stress level had increased dramatically. I took courses in mindfulness, conflict management, and other stress reduction methods. They helped, but I had to keep going back in the toxic mind and being stressed all over again. I wanted to fix the mind. In 2013, David Waldrop, who is our moderator on this program, told me that Erlanger Hospital in Chattanooga had implemented a new medical liability program that appeared to be better than the common resolution practice known as deny and defend. It's called CANDOR, which stands for Communication and Optimal Resolution Program. It's about telling the truth when an unexpected adverse outcome occurs, but it's a complicated program. It can be a complicated program to implement. Dale Hetzler, Chief Legal Officer, who implemented it, said, yes, CANDOR lowered defense costs, claims, and time to decrease the time that it took to resolve a case. But he said, Florence, the best thing about it was it lowered the stress that the patient, their families, and the healthcare provider had when an unexpected bad outcome happened. That resonated with me. And so I became on a team that looked to see if what Dale said was correct. For liability outcomes, he was spot on. We also found evidence that it does decrease stress compared to deny and defend. But the problem is that's only one system. There are several systems that cause burnout. You know, for example, electronic health records, productivity issues that prevent us from spending much time for our patients are just two to name a few. Experts believe that 80% of burnout can be attributed to the system where the professional works. Therefore, the Medical Association of Georgia's Physician Resilience Task Force, under the chairmanship of Dr. Keisha Callens and Mags Lori Murphy, has focused their efforts on how healthcare systems and medical organizations can implement a system that improves the well-being and productivity of their healthcare workforce. So, what is a system that decreases the incidence of burnout when there's so many factors that can cause it? Well, I am on the advisory group of System and Policies of the American Society of Anesthesiologists Committee on Wellbeing. One of my colleagues on the advisory group said, we must get to the root of the problem, the root cause of all these systems that are contributing to it. He said that if we don't, it's just like a whack-a-mole phenomenon. So what's the root cause of the burnout? In one word, it's culture. A medical organization can have a culture that worsens their healthcare workers' well-being, both mentally and physically, or a culture that improves it. Experts use the term just culture for a culture that improves our well-being. Now, this is my one slide. Let's make sure. I think I can do it. 2 clicks. From beginning. Okay, so the term just culture is a concept related to systems thinking. This emphasizes that mistakes are generally a product of faulty organizational culture. In a just culture and incidents, the question is asked, what went wrong? Rather than who caused this problem? Okay, let me get back out of here. Stop share. Okay. That is not to say that there may not be personal errors, but there must be a system in place by the organization to correct both. Dr. Hickson and Dr. Olson will discuss this in more detail. The ASA's advisory group expanded upon this term. We use the term just culture of support. One of the members on the advisory group is on a research team that did a study on burnout in anesthesiologists. Preliminary data is showing a pronounced association between burnout and a feeling of being supported or not being supported in one's work life. So now I have 5 minutes to give you a brief overview of the system I'm talking about. A fact sheet on MAG's task force recommendations and a more detailed description of it is available on our website. The system that we are recommending is from experts on the culture of resilience during a pandemic. It is based on research from the Ebola and the SARS pandemic, and even from the 1919 Spanish flu pandemic. If you have any questions about the system, MAG's contact information is at the bottom of the fact sheet. MAG is working in collaboration with Vanderbilt, the AMA, and the Georgia Nurses Association about this issue. It will take many teams working together to successfully implement a new system in the middle of a pandemic, but we are here to help you. This system can be used by any medical community. It is not just for large healthcare systems. Dr. Hickson and his team have helped small entities implement it, and with senior leadership commitment and a well-respected peer in your medical community who's willing to volunteer to organize the system, this can be done at little or even no cost. So the basics of the system is a two-way channel of communication between the frontline healthcare worker and the hospital leadership. There must be transparency by both groups when they communicate with each other. Honesty builds trust, and it is trust between the frontline and their leaders, which is the basis of resilience during a crisis. First, the hospital needs to determine the concerns of the front line. This can be done by a brief survey at prescribed intervals. The AMA has a great free one available. The organization can assign well-respected and empathetic frontline professionals to talk to individuals in their department. There are some universal challenges of healthcare workers, but many problems are local and require specific situations for their group. For example, an older single anesthesiologist with no children has different concerns than an ER nurse with school-age children. Senior leadership forms a multidisciplinary committee consisting of physicians, nurses, hospital administrators, other. The committee also gets information. They get it from their staff, then they also get it from public health officials and senior officials. When they've made their decision, they refer it to their senior leadership for approval, then they give it to their staff. You know, they tell them about new CDC guidelines, you know, what's the expected projected demand of PPEs versus supply available, and for certain departments, maybe what is available for childcare. So this back and forth communication continues throughout the pandemic and hopefully after it's over. You should know that it is in the reduction phase of the pandemic that the incidence of mental health issues and even post-traumatic stress disorder is at its highest. A reporting system must be implemented by the senior leadership that allows providers to report concerns about their colleagues or even themselves without fear of reprisal. For instance, if they see someone commit a medical error or bully a colleague, or if they are concerned that someone is depressed, they must feel comfortable about reporting their concerns. Leadership cannot ignore a reported problem. Otherwise, providers will stop reporting any concerns. Then the errors and injuries just keep recurring. This is bad for morale and ultimately hurts a professional's well-being and can result in medical errors, as several studies have shown. Now, to determine if there is a problem, leadership needs to develop a method to investigate the reports. If they decide there is a problem, they need to establish a way to correct it, be it a system error, such as electronic health record, or a personal issue. About 15 years ago, I thought that one of my anesthesia colleagues was depressed. I told my chief of anesthesia about it, but the hospital at that time had no resource to help him. A few months later, I was told he was admitted to the hospital because of a nervous breakdown. Now, could the hospital have helped him so his depression didn't get so severe? We'll never know. But I never want to ask that question again. I want to know that we did everything possible to help him. Our country has not faced a pandemic in over 100 years. We need to adapt in productive ways. This will take team effort between the front line, and that includes physicians, nurses, and other healthcare workers, and senior leadership. None of us can do it alone. Most of our audience are not senior medical organizational leaders, but one of the most successful methods to achieve widespread adoption of a new practice is through a grassroots social network. That's you. We at MAG can help you. If you want to implement the system at your institution, MAG's done it. MAG member John Antalis led the team that succeeded in getting the AMA to induce candor at the medical liability program I spoke of. Rob Schreiner, president of Wellstar Medical Group, led the team that got Wellstar to decide to implement candor. Let us help you. Give us a call. Thank you. I turn it back over to Randy.
Thank you, Florence, for that excellent overview. Our next panelist is Dr. Gerald Hickson, who is the Joseph C. Ross Chair and Professor of Pediatrics and Founding Director of the Center for Patient and Professional Advocacy at Vanderbilt. Additionally, Dr. Hickson serves as Vice Chair of the Board of the Institute for Healthcare Improvement. He's also a board member of the University of Southern California Keck Health System, and he previously served as chair of the board of the National Patient Safety Foundation. Dr. Hickson.
Randy, it's an honor. Being a Georgian myself, I'm honored to be with any collection of individuals that are living there, and I'll always say go Dogs. Now, I don't say that often with Vanderbilt, but with our Yale colleague on this program tonight, we both like Bulldogs. Now, Florence gave me a tough task, and so I get the task of talking about developing a plan. And I generally find that pretty boring, but I think we need to recognize that we're not going to deal with physician or nursing or pharmacist well-being unless we've got a plan. The question is, where's that plan? And the problem is we don't often recognize we need a plan until we're knee-deep. That's the challenge. But it's time to get started today. And let me just say the unfortunate truth, that is that we are not going to deal with the issue of physician wellness and well-being without investment. We don't do it on people's spare time, and it requires an organized and a system approach. Next slide. So, you know, when we think about why we got into medicine, I think that's where we have to start. I think the notion is that we want to deliver care that we feel proud of. We want to deliver care that our neighbors want. That's why we got into medicine, and that's one of the things that supports us against the issues of burnout. And so as a quality and safety officer of an unnamed institution up the road for many years, I wanted failure-free operation, and I recognize that that does not occur unless we have a vision. And I'm going to continue to come back to talk to us routinely about how we as professionals have to have a vision, and we have to have a set of defined core values, and we need to agree what they are. And finally, as Florence said, we got to have a right culture. Now, culture that's right is one where people are willing to speak up when they observe something that just isn't right, when there's a disturbance in the force. Because I have learned as a researcher as well, in listening to the observations of patients, families, and fellow staff members, they see things. And if we empower them to speak up and do it in a partnership, we are positioned to achieve what we seek to achieve. But that requires our team members having psychological safety. So if they speak up, they're protected, and a level of trust that leadership collectively, whether we're talking about a 2-member practice or a practice with 2,000 professionals, They all need the same, and that is psychological safety and trust. Next slide. Now, this slide helps me to sort of transition my thinking. When I left the University of Georgia 50 years ago to go to Tulane and studied at Charity, that was a real shame and blame culture. When things went wrong, there were people to blame. End of story. And it either occurred because I was not motivated or I was not very bright. And then fortunately, Jim Reasons came along and taught us that, gosh, we take perfectly good human beings and we put them into dysfunctional systems and bad things happen, but we've gotten off track. And Jim has changed his view, thank goodness, that it isn't the issue of either or, it's both. We don't deliver care that's high reliability, that it's high quality, unless we have a combination of intentionally designed systems. That means that if we need protective equipment, if we need to wash our hands, if we need to do the things that we need to do, it needs to be easy for the clinician. And as an administrator at Vanderbilt for years, one of my jobs was to listen out to those reports Florence mentioned and to be sure that we were fixing those dysfunctional systems. But if we fix those systems, what should we expect of the professional? I had a problem several years ago with getting people in one of our laboratories to wash their hands. And they told me, well, it's because the sinks are in the wrong place. So I spent $6,000 and moved the sinks. The problem was after we did that, they didn't wash their hands any better. So I want to make the point that as we go down this pathway, and one of the issues that drives burnout is that, yes, we have dysfunctional systems. We have to fix them. But we also have to expect each other and hold each other accountable for washing our hands and doing all of those other things that we know to do. Next slide. Now, we've been fortunate enough to have a network, and these are sites where we have been collecting data. And one of the things that I mentioned earlier is that we collect observations about unprofessional and disrespectful behavior, which is one of the byproducts of a burned out clinician. We published a paper just a few months ago about that fact. And since the COVID pandemic has started, we have collected data on patient and staff observations better than 200,000, of which 20,000 have been specifically related to COVID stuff. Next slide. And what we found is whether you live in the East, West, North, or South, humans are humans. We always want to believe that we're terminally unique. My practice is different. Well, I hear you. It's just not exactly true. And what we've learned and why we have to have an organized plan is that when we look at organizational stress in a crisis, which does dial it up on all of us, there are 5 specific phases. And what we've learned is that the kinds of challenges professionals have in each of those stages differ. And if we're going to be thoughtful about supporting our colleagues, we need to know what to anticipate and how to address. And so unfortunately, just a week ago, I was on the Gulf Coast and made a really bad decision to wait out a hurricane. I knew it was coming. I saw it on the radar in many ways as we anticipated the COVID pandemic. I went and I watched the radar each day, convincing myself that it would not come to my condo. I was bad wrong, but in that process of bumping elbows that we saw with COVID, we had a preparatory phase. But it's really interesting that once the winds started blowing and the rain started falling and we began to see early cases in COVID, now I'm not so sure that my planning was as careful as it needed to be. This is why you have to have an organized group thinking about those things. And what's been fascinating at looking at these complaints that we get about professional conduct, they often relate to the fact that I've been redeployed. I'm not sure we're going to have this right. What did you really say about how we handle ventilation of a patient in this circumstance? And then the surge hit. And we've seen exactly this. But what's interesting is that the complaints we've seen about unprofessional behavior are often driven by the crisis and individuals' personal fear. Am I going to catch this myself? Am I going to take this home to my family members? Do I need to bathe in the garage? What do I need to do? These are real. And if you have a group that are volunteers working on this versus an essential element of your system, you can see that one is going to function much better than the other. And then we go into survival guilt, and then we're overwhelmed by surge 2 or surge 3, and then we'll have to deal with the lingering effects. But the point I want to make by this slide is that in these 200,000 reports we've looked at, the needs of clinicians differ, and we need a group looking at it, because if our professionals are not well, we're not going to deliver the kind of care we need to deliver. And that occurs whether it's a pandemic, a hurricane, a tornado, or if we make a medication error that results in a patient's death. Next slide. I want to show you a physician. We're going to call this individual Dr. Hickson. And these are some of the reports that we've gotten from our sites. Dr. Hickson was running the code. It was a rule out COVID, and Dr. Hickson screamed because we needed supplies and we didn't have them, and we asked him to remain a little calmer, and he just couldn't manage to do that. Second report. This is the third day seeing Dr. Hickson without a surgical mask. When he asked, he responded, well, you know, it's really okay, and I really like the attention that I'm getting. And a third individual who's been wearing the same set of gloves for multiple days. The question I'd ask everybody listening tonight, this professional, really? Are these behaviors safe? Or are they a sign that we have an opportunity to fix our dysfunctional systems because we've got a group working on it? And what I think is really important, what can we do to help Dr. Hickson at this particular time? And if we're not collecting observations, if we're not vigorous in providing follow-up, how do I know the level that this human, the level of stress they're facing, and how can I know the right thing to do if we're not engaged? Next slide. One of the things that we've learned in our research over the years is that professionals like to talk about each other. They really don't like to talk to each other. We also learned, as I've said many times, you can't do this work on the basis of people's extra time. There has to be, if we are serious about our human resources in our health system, we've got to have defined plans and programs in place to support, to honor, to call out, to encourage. I'm going to talk about the other side of the equation tonight when people are not behaving well, because they often are not behaving well because they're in trouble. And as fellow professionals, I want to be sure we can reach out and provide the right level of support in the moment. Before, yes, as a part of the program, but now we're in a crisis. And to do that, I've got to have committed leadership and a real partnership between physician leadership and administrative leadership. That's serious. It has to be real, and all parties have to sit at the table. If we're not getting the supplies that we need to treat the patients that need to be treated, do I have a senior administrator sitting there working as a partner? Are we looking at each other face to face? We have to have that level of commitment. Do we have a project champion? I believe very strongly that there has to be a nurse, a physician, a pharmacist who take the lead, that we are going to continue to articulate the needs of our team members and be sure that administration is hearing, and in the same way that the concerns that administration has about our performance are getting shared back to the professionals. There has to be that two-way partnership. We have to have processes. They begin by articulating our goals and outcomes of care we're seeking, but they also have to have a way that we share with each other when we do, in fact, bump into one of these disturbances in the force. And finally, I went to the University of Georgia, and I believe in counting. I got to be able to measure performance. I need to know how we're doing. And in addition to that, I want to be sure that we've trained fellow clinicians to knock on people's door and have the kind of conversations we have to have to know how we're doing and to encourage right professional behavior. Next slide. One of the things that we've learned to use at Vanderbilt and now at these other 200 sites is this pyramid to help us know how to engage with each other. Now, this would never occur, but I'll use Florence as an example. So if Florence walked into a building and refused to comply with employee screening. She just wasn't going to do it and declared, what you're doing is stupid, and just walked in the room. Just proceeded. Well, would we do nothing and say, gosh, that's Florence? Or, gosh, I'm not really sure that this plan is really important anyway, and it's okay, and I'm busy? Or do we engage with each other? And so we feel very strongly that when we challenge each other and we don't get the right response, we're going to send a peer to knock on Florence's door. And we're going to share with her what we call a cup of coffee. Florence, got this report. We share 100% of these reports within 2 days. Don't waste time investigation. Go directly and say, Florence, I got this story. The story did not seem consistent with who I know you to be. Now, Florence, I know there are two sides to this story. People often get things wrong, and I just couldn't believe this was you. But you know what? All I want you to do is reflect on this disturbance. I know there are two sides, and Florence, I trust you to do the right thing. You're a valued member of this team. Have a nice day. It is powerful how effective these peer-delivered messages are. And as I'm going to show you data in a moment, most of the time it's all it takes. But a few. Dr. H, in this particular circumstance, unfortunately, because he's not doing well, continues to escalate and is giving us a sign something else is going on. Next slide. One of the things that we know from our collaborative research, we have about 100,000 physicians now that we get patient complaints about. We have about 60,000 physicians. We get staff reports. And the one thing I want you to know and to reassure that even during a pandemic, 90% of professionals never get a report of unprofessional behavior. 90%. And unfortunately, what we found, and you see that red dot, unfortunately, that represents Dr. H in this particular case, who is at the 99th percentile and not in a good way. We know that those who are in trouble before the pandemic become in even more challenged circumstances within the pandemic. They're random reports, but it's amazing to me how professionals hold it together. Next slide. So unfortunately, just shortly after there was a recognition that Dr. Hickson was having more than his fair share, another complaint comes in, great concern by the staff about the wellness of a colleague. And I want to be sure that we are prepared as quickly as we can to get into his office, to find out what's going on, to be sure we link him to the support that he may need, because that's a professional thing to do. Next slide. One of the things that I've been struck with in so many of our research studies are about the failures to address. And so I started this work years ago because we knew that 2 to 8% of physicians accounted for 80% of all malpractice related dollars. And it was amazing that they could be identified by the observation of patients. And it's all about disrespect. And we've learned very effectively how to address that challenge. Then recently, we've looked at surgeon performance. We've done 2 studies now looking at surgeons that model disrespect. And in comparison, using NSQIP data to surgeons who model respect, huge differences that if you're a surgeon, if you're a patient and you go in to see a surgeon who's disrespectful, you're going to have bad outcomes. And we know that this drives nursing professionals and others out of those environments, which bring huge cost to institutions. If you look at the ROI related to the cost of failure to address disrespect within your environments, gosh, it's huge. And it's one of the reasons that administration needs to partner, because as I tell Florence regularly, there is a huge cost of doing nothing, and we all collectively pay it. And I want to be thinking about what's in the best interest of my colleagues, as I hope someone is thinking about my interest. Next slide. We finished this work now tracking 86,000 physicians now, with up to 10 years of tracking experience looking at their performance. Now, this is in our patient complaint model. And in that model, you'll see that 40% of physicians in a up to 10-year tracking never get a single report. And so when a complaint comes in, we're sure that it's shared, and we let people self-regulate. And of the 51,000 that effectively get a virtual cup of coffee, only 2,200 show us, like Dr. H did in this model, a pattern. But if you send a peer out to visit those 2,200, which we have, only 300 fail to respond. And of this 300, you need a written plan, and many of them need mental and physical screening and treatment directed by that. But of that group, you're left with only 79 who are absolutely unable to respond. And in a paper we did this last year, 24 of them have evidence of early cognitive dysfunction. 4 of them had CNS lesions, otherwise not suspected. But I want to show you this data because if we are courageous enough, if we partner with health systems, if we get the partnership we need to build a system to support each other, we can help our colleagues before it gets too far, while we're also doing all of the important work that we have to do with wellness and resilience, but we have to deal with the whole package. Next slide. The last thing I want to show you is a slide we just finished, because in these 200 sites, we've interviewed their CMOs, CEOs, and chiefs of staff, and we've asked them, what are the leadership practices that you have found most helpful during this pandemic? What are the things that you would share with others about how we support physician well-being and resilience during these crisis times? And what's so funny is that they all start with, again, articulating values. For our burned out clinicians, for each other, we have to remind each other why we entered the profession, but that's not sufficient. We have to have leaders that have modeled professionalism themselves. They have to communicate clearly, especially when treatment plans are changing. But look at this one in the bottom. We have to continue to expect excellence of each other, and it's hard, and it's particularly hard during a pandemic, but that's exactly when professionals stand up. And if they've got an organized approach, it fortifies them in that work. Last slide. And I'm going to go back to a model of professionalism. It's who we are. And we need to remind each other, we need to partner to support. And with that, I'm going to finish my comments at this point, and I hope there are a lot of really tough questions in the Q&A.
Thank you, Jerry. Our next panelist is Dr. Christine Olson. Dr. Olson is a hospitalist and is the Chief Wellness Officer at Yale New Haven Hospital. She served in the Peace Corps. She has a diploma in tropical medicine and traveler's health. And Dr. Olson is the co-author or author of several works, the 3-domain model of professional fulfillment, the AMA Steps Forward module on creating organizational foundation for the joy of medicine, healthcare harmonics, fine-tuning the tension between stakeholders, and Mind the Gap, career and financial success for women in medicine. Dr. Olson.
Here we go. Thank you so much for having me. It's a real honor, a pleasure to be here. Thank you to Dr. Rahimi and Dr. LaCroix. Great to be here with Dr. Hickson and all of you. I'm going to share some slides with you. Okay, so it's great to follow Dr. Hickson because we have a nice complement here, because he emphasized how we are accountable to one another in creating the environment that we have. And the environment, as Dr. LaCroix was saying, is a very big part of how we feel at work and doing our professional duties. So I'm going to complement that and talk a little bit about the system responsibility. And I'm going to give you a few models, and it will set us up for the conversation and the Q&A, give us something to think about. So I'm just going to briefly go through those. So I'm going to show you a model of professional well-being when things go right, when they go wrong, a model for addressing professional well-being and responding during the pandemic, the structure and the psychological first aid, and meeting the needs of caregivers. And like Dr. Hickson was saying, how do we measure and how do we hold ourselves accountable to that? So here is one model. It starts at the time that Medicare and Medicaid come onto the scene in 1966 with Dr. Don Abedian, who's kind of one of the forefathers of health services research. And he started talking about how are you going to put all these stakeholders together, quality, safety, insurers, providers, and who gets to say what and how do you do it all together? How do you orchestrate all these people? So we're now 50 years into this process of trying to perfect this, of how we get everyone working together. So through the years, and Dr. Barr of Stanford in the HMO era added to this mapping, and then I and my fellowship also add to this mapping, is that you can take wonderfully credentialed top-notch doctors, put them into this structure and expect to measure outcomes and think that you're going to get the best outcome. But as Dr. Don Abedian said, there's structure and process. And so there's a culture that all of this is going through to get that outcome that you're measuring. And what goes into physician satisfaction? It's their ability to be efficacious in the workplace, in service to their patient, and to get a quality outcome. That's kind of the essence of what makes a satisfied physician. So that gives us something to think about. And then I'll take you to the 3-domain model, which captures some of these other elements. So when you have professional well-being, you're more likely to give access to high quality care and a great patient experience. And if you work at an academic medical center, you're also looking to make sure that you're giving the best education, research, and leadership and the doctors for tomorrow to lead American medicine. So when it doesn't go right and it goes wrong, then you get withdrawn physicians who may be burned out. And what do? They physically remove themselves from clinical work. They may do that by reducing their clinical time, reducing their FTE, retiring early, rerouting their careers, a revolving door. They might withdraw psychologically where they're present, but they are disengaged and they're not going to give the best patient experience. They might be accidentally reckless, creating errors. They might be risky. They might have unprofessional behavior. And these have consequences for the individual personally. It can damage their relationships at work and at home, substance abuse, and even suicide, as was mentioned. And professionally, it can lead to bad outcomes professionally that also hurts that person's career. So how would we go about tackling it with a model like this? So this is the 3-domain model, and it's very basic, but it's also easy to kind of capture a lot of the elements in here, and it's easy to talk about. So you've got the culture of wellness, the practice efficiency, and the personal resilience. And that's how we're going to kind of create that environment that we talked about in the first model. So culture of wellness, just to give some basics to what that might look like, is that you have the quality of the leadership, how they engage, how they value, how transformational servant style leaderships or collaborative distributive styles, that they engage and they value and everyone feels seen and heard and have the psychological safety that was mentioned earlier. The collegiality, do you feel valued and appreciated and connected to your colleagues? That's also where professionalism can fit in, of how you are being accountable to one another, and the kind of teamwork you have with your allied professionals, as well as belonging, diversity, equity, inclusion, and feeling like this is your professional home. And then practice efficiency can be a lot with your workload, the pace, the flow, especially with administrative complexity and the EHR and some of those things, if they're optimized so that it is not the main focus of your day or your work, that your patient care is really the center of your work. And that personal resiliency, that at work you do have that peer support, you do have the psychological support that you need, and that you do have some control over some work-life balance, so you have time to rest, rejuvenate, come back to work ready to go. And that kind of goes with the joy and job crafting, both for your life and your job, and a lot that goes into knowing what your values are and how to get the most out of your work. we put together, so when we talk about what are the tensions of putting all these stakeholders together with getting high quality care and making it accessible at the most affordable cost to the population, we talk a lot about those tensions, and we also talk about some of the evidence-based things that can be done to address some of these, which we put together some chief wellness officers around the country that I work with through the Physician Wellness Academic Consortium led by Stanford. We made a compendium of some of those things. Now, as we transition into a pandemic, before the pandemic, no one wanted to be told that they weren't resilient, and certainly they are the most resilient people that around, and we know that. But we also know that it also takes time to have a culture change, to move to these new paradigms, and also to be able to have greater mastery over your choices so that what you can control, you do control, and you have a sense of well-being that way. But people mostly wanted to talk about this, the drivers of their unwellness. They wanted to talk about the culture and the efficiency. But then after the pandemic, the interesting thing is that these things kind of fell quickly in line as the most important things became the priority. And the other thing is people were dealing with a lot through the uncertainty of not having known therapeutics, not knowing what this novel virus was going to do, and the stress of quarantine and no time to decompress, going home and having to homeschool, not being able to go on vacation, not being able to get away, not being able to see elderly parents, or worried that you might bring something home. So there was a lot of stress. And so then we started moving from here down to here to manage the pandemic. So one thing we did to put together a strategy for managing wellness during the pandemic is, one thing we knew is it was hard to be focused at work if you were worried about home. If you were worried about, am I going to see my parents again? How are they doing? Am I going to bring this home? So the first thing we started to do is try to secure everything people were worried about at home. What could we make showers at work where you could shower and put clean clothes on before you went home? Could we make hoteling away from home if you were worried? Could we make sure that you had all the supplies? We set up groceries in the cafeteria. What could we do to enhance childcare? If people wanted to have wills and that was important to them at the very beginning when no one knew what was going on with this virus, that's always part of your employee assistance program. So that's built in. And so just letting them know that that's always there for them. And then trying to build creative new ways to rest, relax, rejuvenate. So we built that into the website. And then at work, we wanted to make sure that we decreased the uncertainty as much as possible. We put them in control as much as possible. So we made sure we had up-to-date algorithms for the treatment. We made sure that the PPE policies that were changing all the time were easy to find and up to date. We made sure that everyone had PPE. We let them know what the testing situation was and those algorithms, and put up training videos and what the latest is on policies and patient and family support, because we had limited visitors to the hospital, and that was very stressful, kind of a moral injury that people were scared and alone without their families. And then the other thing we did was make sure that we had a psychological safety net. And for that, we teamed up with the Department of Psychiatry and Psychology, and we put together a number of different levels of care. So you could get individual care. We made sure that the website had self-care recommendations and how they could do it, how they could optimize sleep, very big for coping, that you get good sleep, really important. And that we put quiet reset rooms near the high acuity areas, so that if you were very overwhelmed during some of that care time, that you could go into a private space and recollect yourself. That could just be a quiet time, but we also put ways to access mindfulness exercise, how to reach out to somebody one-on-one, how to get a spiritual blessing, whatever was right for you. We made sure that you had a whole menu of different choices where you could reach out for something that was right for you. We had one-on-one program. We had our Yale Stress self-assessment that pulses all the time. You could just check in, do your own self-assessment. That will take you to a one-on-one where someone will reach out to you within 24 hours. Anonymous, confidential, one of our professional psychiatrists or psychologists will reach out to you. We also had proactive one-on-one wellness checks where you could opt out, but everybody would have a chance. They were reluctant, a little skeptical at first, but once they had a visit, they really liked it and heard about all the different things that were available to them. And then we have all different ways of getting mindfulness-based stress reduction or cognitive behavioral therapy types of platforms where you could reframe the experience. But some of those most important ones have to do with team huddles and decompression with your team and reframing the experience and finding the positive, and also doing those through town halls or Schwartz Center meetings. Just a way that the community stayed connected in some way in the meaning of the work, what's positive, what's good, a shared experience of loss or fear, and then reframing that. And then after going through a period, you have to allow yourself and your community an opportunity to kind of grieve what they've been through or the loss or the change. But after you get through that period, then you can start to reimagine what you want your healthcare system to look like. And it can actually be a catalyst for reimagining and reinventing and a real positive thing. Very briefly, we also used this, Tate Shanafelt put together a nice paper with this table of what healthcare professionals wanted during the pandemic, that they be heard and that they get to contribute their expertise to what's going on and feel in control of the situation a little bit, that they be part of that. Protect me with the PPE, prepare me with the information, support me with those things that I need to have my basic needs met during a pandemic when I can't get to the store or get the toilet paper. And care for me holistically. And as Dr. Hickson was mentioning, how do we hold ourselves accountable? How do we move the needle? And so every year we have our annual wellness survey, which collects information on all of these domains and all these aspects. And we use the well-being. Yes, we check satisfaction and burnout and wellness measures and how people are doing overall. And that's really important, and we want to make sure that we're tuned into that. But we also use that just as importantly as a pointer. It points to where are high yield opportunities to improve in the culture, efficiency, and resiliency. And so then those go out to our departments and our sections, and there are wellness leaders who in those departments and sections who then take charge of moving these initiatives forward within a group where we all share best practices and help one another. And we keep it moving forward, and in an iterative process, we work to get better every year. And so that's a kind of a holding accountable on the system side to complement how we hold ourselves accountable for the environment we create for one another. So thank you so much for having me. It's really a pleasure to be here.
Thank you very much, Dr. Olson. I think we're going to open it up now for question and answers. And Ryan LaRosa, I think, is going to be the monitoring that. And Ryan, do you have questions?
I have a question. So this question, one of my colleagues in the ASA advisory group, Kenneth Sapire, has been a senior anesthesiologist at MD Anderson. They hired the McChrystal group to come in and change their cultures a few years ago. And I thought it'd be nice if Kenneth could just give us a couple of minutes about what has it been like for them since they have done that. Kenneth, Kenneth, you need to raise your hand so you can talk. Do we have him with raised hand? I asked him to. There he is. Great. This is the one who said we can't just whack a mole. Kenneth has been wonderful. So Kenneth, tell us about what's happened at your department since the Crystal Group has come in and helped you.
Okay, can you hear me?
Oh,
Can you hear me, Florence?
Yes.
Okay, thanks for asking. I think we had Miss Crystal Group come in around 2018, and there was a lot of leadership issues around that time, and it was a period of change. The system got in the Crystal Group, and we went through a very strong team building process and looking at where we wanted to be in 5 years' time. So that was, say, 2 or 3 years ago now. And through this process of developing teams, trust and respect for one another, at a group level, we had very strong focus groups where we got together, nurses, physicians, anesthesiologists on a consistent basis, as much as you can while running an operating room. And we were able to itemize things that were problematic. We addressed the things that are constantly chafing us, like non-clinical time, safety, productivity, quality, and we decided together what the things we wanted to do at a local level. Then we had a retreat. We got together, we spoke about the different aspects of care that we can do for one another, the wellness programs, and then the clinical programs that we could improve on. And then as this developed, our ability to trust one another and communicate effectively with one another increased dramatically. And this was shown we have every other year we have a survey, and our burnout in our group dropped 7 to 10% in certain of the groups compared with the prior years. So this work was a dramatic shift for us. We did get new leadership. Our division head changed. The president of the hospital changed, and there was like a palpable shift in the way that the organization started moving together and prepared us for a very dramatic year, including flooding, the CMS evaluation audit, and now COVID, and now this weekend, another flood. So we're constantly moving, there's constant challenges, but this kind of team building really created a strong group feeling and a culture that we felt that we could rely on, which we're starting to call in our personal anesthesia group, a just culture. I'll stop there, Florence. Hello?
Thank you. Ryan, did you have any other questions? I can always ask a million of Dr. Hickson and Dr. Olson, but I think, are there 2 more questions in the chat box?
Dr. Rahimi asks, how do we create more real-time measures of wellness, both at an individual and an organizational level, as opposed to annual surveys and any metrics on the horizon?
I'm sorry, could you slow down that question again? I couldn't hear it all.
Yeah, it's in the Q&A box if you want to take a look as well. So
Okay.
it's how do we create more real-time measures of wellness, both at an individual and organization level, as opposed to annual strategies, annual surveys, and any metrics on the horizon?
I can answer that because we have worked a lot, Meg has worked a lot with the AMA Wellness Group, and they now have this phenomenal survey that they are offering free of charge. It's the first one. There's 14 questions, demographics to know where you're coming from if you're a nurse, OR, ER, outpatient. So they get a gist of where you are. And then every week they do a little 2-question on your phone. Sir, how are you doing? So, and this goes on. And the beauty of this data then, this survey data goes to the AMA. They analyze it and bring it back to your senior leadership de-identified, because remember, it has to be anonymous, no fear of reprisal. If they don't have enough numbers, they don't send it back because they can de-identify. But this is all done free of charge. So this is if you want numbers, as someone who does health economics, I love numbers. So that's one way. As Dr. Olson said, the town halls and with the frontline leader is also a great way to do it. But there are ways in this to do it and do it easily and inexpensively.
Yeah, I'll also comment that there is, well, one thing on the mental health side, we're doing the Yale Stress Self-Assessment Pulse, which is always open, so we can look at what stress is doing over time to some extent. We also have ways of checking the temperature on work units. That's one way for well-being, but as also for real-time data when it comes to workplace efficiency and culture and retention and things like that, which are indicators. Efficiency being an upstream indicator and retention or losing people being a downstream indicator, is that we're starting to try to validate the survey results with real-time data, whether that's the EPIC profiler or whether that's our EHR retention or PTO use or FTE use. There are a lot of real-time data that we can start to validate so that we can have dashboards that you can monitor over time. So the goal is to move in that direction so you don't have to do a perception of work culture all the time. So you'll have something. So that's one.
I have a question for really all of our panelists. What resources are available for a physician who is practicing now in an environment that does not have a culture of wellness or of well-being? What resources are there for someone like that?
MAG. The MAG Physician Resilience Task Force, we've been working with Dr. Hickson. Dr. Hickson's a huge resource. Dr. Olson, you didn't know you've been adopted now.
Oh, wonderful.
But we're working with Dr. Hickson, we're working with the Georgia Nurses Association and the AMA. So contact us. Lori Murphy is available. And we will do what we can to help you. And if we can't do it, we'll find somebody who can. Because there's no way you can do this alone. I can't do it alone. It's going to take usually, in fact, I got this from Dr. Hickson. He said, Florence, you need to get your chief medical officer and your chief nurses officer. If you don't get both groups together, it's not going to happen. Am I speaking correctly, Dr. Hickson, or what are your thoughts on it? Because you've implemented it at small places that don't have much money. Right now, even the large healthcare systems don't have extra money. How would you do it cost effectively, Dr. Hickson?
Randy, you're asking the right question. And the problem is that first is a recognition that all of this work is a marathon. You cannot change culture for 3 to 5 years of work. One of the things that was so articulate by our colleague who has been at MD Anderson is the fact that you've got to get people talking. So Randy, unfortunately, there's not a quick fix. I got a call today by somebody in another state because they've got a physician, and the physician has been behaving this way for how long? 20 years. And now in the middle of COVID, we no longer can tolerate it. This is a tragedy, but it is not something that's going to be fixed easily. And I've been unbelievably concerned about the health and well-being of small facilities, small practices, who have to make real tough decisions about what can we really do. They can look at Yale and say, gosh, Yale's got all the resources in the world. They can do all of this stuff and all of these surveys. They say the same thing about us. But the question is, what do we do here in the real world? So the first thing, and this goes back to what Florence said, it is the notion of getting concerned professionals beginning to dialogue with each other. Number two, We still have to have privileges and go in, and I'm going to admit my patients in a facility. And how do we get the medical staffs to begin to sit down with an honest, fair dialogue with the system administration to say the well-being of your clinical team, the nurses, the physicians, the pharmacists, I include them all, really important to what care is delivered by this facility. And we want to do a really good job in partnership, but we need to be able to have not adversarial conversations, but conversations that say we recognize their limited resources, but gosh, we want our team members to be doing well. And it's amazing what happens when people sit down. The great value of the surveys, and I hate surveys, but their value is they give you a reason to sit down and talk about what the findings are. And that's where the value comes. So that's number one. And if that dialogue doesn't start now, we won't be where we need to be in 10 years. And I'm not going to be silly to say you can, and I see this all the time, and I'll let Kristen talk about this. You bring in some course and we're going to make everybody take the course and suddenly we're all going to be well. That's just not how the world works from my view. And we start and build the elements of a program, but there's nothing quick about it. Christine, what would you add to that statement and disagree with it?
So, well, I agree with everything that you're saying, and also I will add to it. There are a couple, it's hard to dissect the question to presume that you're talking about mental health well-being versus some of these other aspects. So I'll start with mental health. So we have a lot of private practitioners in our community who aren't necessarily captured by our employee assistance program. And there are a lot of things available, and I vetted them all, like the physician support hotline. It's manned by professionals, fellow physicians. If you wanted to call and have some debriefing, some decompression with them, to get some, I don't think they call it counseling. I don't think they call it therapy because they're volunteering their service as a peer-to-peer, but they are professionals. There is another texting hotline, and I was trying to find it real quick, but I couldn't. I think it's the text hello, the 741741, which I've also vetted, is another way to text with someone and get some help if you wanted to talk to somebody. The National Suicide Prevention Hotline is very professional. I've vetted all these. They are really top notch. So if you just wanted to talk to somebody and find out what's out there, they're very lovely. They're very wonderful people. And then you can also go to our Care for the Caregivers site because it has a lot of resources and you're welcome to use them. If they're there and it tells you how to use them, you're welcome to come to the Yale Stress Center's mindfulness, stress reduction sessions. You're welcome to come to our town halls and our Schwartz rounds. Our colleagues from Georgia, of course, we would welcome you. And also there's some online cognitive behavioral therapy things, and until they shut us down and say we've got too many people coming from everywhere, please feel free to use them. They're some nice resources. The other things that when it comes to practice efficiency, if you have your own practice, you have a small practice, Christine Sinsky is somebody from the AMA. Dr. Sinsky, a primary care doctor, talks a lot about this. And you can have monthly meetings on workflow mapping where that's specifically what the meeting is about. We're going to map out our workflow. We're going to look for efficiencies. And once a month, we're going to look for efficiencies and we are going to maximize and we're going to make our practice the way we want it to be. So there are a lot of different resources. Please come check out our Care for the Caregivers site. You're more than welcome to those resources. And as we are putting together a larger resource list, I'll be sure to share that once we have it available.
Randy, one other quick comment here just in follow-up. You heard all the things that Christine articulated. How can any single group practice understand that? And this is the reason I'm going to continue to hammer that each health system has to have embedded within a defined program, because you need someone who owns looking for the latest, best, and is there to provide as a resource, so that when individuals within that large group, and I mean people who have voluntary privileges that come in, know that they can go to a place and find the resources that are out there. This is why I continue to say this is not done on people's spare time. And that's the thing we've done. We have diminished the value of wellness by doing it on spare time. We need to hold accountability that it really is essential to the care delivery. I said one last, I lied. The other reason that we've embedded all of our work in quality and safety is that there is a financial note. And so if I need to use that and outcomes of care, because there's a huge difference in surgical site infections related to that surgeon, whether they are healthy and whether they feel good about themselves, or if they walk into that OR and create fear. That has a cost implication to the hospital that makes having a program well worthwhile.
We got one more question in the chat box. Pretty decent segue there, Dr. Hickson. So we'll maybe let you pick it up from Dr. Doss. It says, how can we initiate wellness interventions that do not result in direct ROI for the institutions?
So, like Florence, I tend to the economic side, because at the end of the day, I've got chief financial officers that always want to argue it ain't worth it. Now, we as professionals understand it's inherently worth it. And sometimes I can argue, and we got this work started at Vanderbilt just simply on the force of sharing stories. And we had a group of about 18 physicians across the system that just simply said, we need to take these actions. But to this very important question, it isn't easy early on to calculate the ROI. You have to start with a few stories, but there are other institutions nationally that have learned some values that may help you sell this notion, but it's still important even if we can't share it. So please don't misunderstand my position, but gosh, I still have to deal with that CFO.
Sure, I can add to that also. I think the paper by Tate Shanafeld on making the business case also helps to make that burning platform, as Dr. Hickson's familiar with this. And also there's a calculator at the AMA site that shows that you can calculate your ROI on reducing burnout. So to help you to make that burning platform that it is worth doing, and it has all those downstream consequences to quality, safety, the patient experience, and access and cost and turnaround. The turnaround alone in retention at academic health centers is $1 million per doctor in that turnaround cost. So it gets to be quite costly.
Yes, and I would agree with that. In fact, that is something when we address this with our leaders, we have to discuss the point about to hire a new physician is between $500,000 and $1 million, as Christine said. The other point, though, is that one business consultant in Ohio said that, Cleveland Clinic is doing this. They're doing a great job, a lot of teammanship. And he said a lot of the community hospitals in surrounding areas were upset because all their nurses were going to Cleveland Clinic and they just couldn't understand it. And he said, y'all, you have got to change your culture. The way you're treating your nurses, they're out of there and they just don't understand it. They're so used to the top down, they don't get it. So they're getting hit culturally because they're losing staff. So there is a payback, and it can be pretty acute, especially if one hospital is graded and word of mouth gets out. They treat me wonderful. I'm going to Vanderbilt or Yale. You're not going to go where I'm heading or whatever. But and so you get the best people. So it's money. Those are the best people. So people talk. And number two is, they say the number one reason to leave a job is not because of money, it's because you don't like your boss. So it's definitely a money issue.
Dr. LaCroix, on that point, we have a question from Dr. Ellen Friedman talking about organizational changes. Dr. Friedman, I'm going to unmute your microphone so you can ask aloud. All right, you should be, you're self-muted right now. If you unmute your line. Okay. All right. Well, her question is, these resources, the resources you all were talking about, appear to be related to individual results. Dr. Friedman, there you are. We got you live on there. You go ahead and with your point you would like to make in question.
Okay. I appreciated your interest in the institutional organizational contributions to burnout and to our current situation. Most of the resources that I heard you identify were for personal improvement in terms of resilience, spiritual uplifting, and I think all of those things are wonderful. But I still come back to institutional responsibility or component of shared responsibility for organizational health and individual health. And I am interested in if there's something other than ROI that you can use to motivate institutional changes. I mean, everyone talks about the electronic medical record. I in fact see that getting more onerous rather than easier on faculty. So I'd be grateful for some tips on how you impact this on an organizational institutional level. And I'm really interested in that AMA RO, that calculator. Is that just for burnout? Is that the main thing that calculator registers?
Yeah.
Thank you.
It's turnover. And one of the biggest factors in stress or burnout is what's your turnover rate? I talked to one hospital leader and they've got their turnover rate's minimal, their retention rate's good, but they've got one place that has a high turnover rate. That's a problem, and they're losing big time bucks. And as far as where's your problem? That's why you have to have, the organization has to develop a reporting system so you can report anything without fear of reprisal. I'm curious to know how Dr. Olson and Dr. Hickson developed that system. But especially for and it depends on the problem, which group gets it. For instance, electronic health records, the AMA has this program about getting rid of stupid stuff. Some departments, it works great. Other departments, it's terrible. So you have to have this group that are good in that kind of thing. And I would never be on that group. Maybe Dr. Olson would be. I don't know about Dr. Hickson. But so the organization has to see the problem and know where to go. If it's personnel bullying, that's one area. EHR, if it's, I don't have enough childcare, so it depends. But there's the big thing about the institution is they need to hear from you. Then they need to figure out, is this really a problem? And if it is, what group can help them, and let's try it. So it is an organizational system to help the group and also individuals. Dr. Hickson, or about either of you, how do you implement a program, there's no fear of reprisal? Because that's the starting point, trying to get people, they're afraid to say anything. How do you do it?
So Florence, the pyramid is key. You need a defined approach about how you engage with other human beings, and you need to have a team. That's why you have to have a program in place so that within our environment, 4 times a year, someone seeks reprisal that we become aware of. And that number of 4 has existed now for 20 years. And in our larger collaborative network, it runs about that same rate. There are some humans. So number one, when people report in good faith, there are certain kinds of complaints that we don't just go serve a cup of coffee. They actually represent 2.5% of all the data that comes into the system. And those are circumstances in which a human lays hands on another human. It is a circumstance in which there's an assertion of discrimination. It's an assertion in which there has been the suggestion of a violation of sexual boundaries, or when someone assaults a safety reporter. And that escalates that particular event, because if we are going to protect the safety of people reporting, there has to be consequences when people violate certain boundaries. But team members have to understand, and peer messengers have to be trained to help colleagues pause before their desire to know. And then the organization can't blink. That's why when you go back to the required elements, if your senior leadership of your organization really is not committed, you don't have a chance to sustain this work. Because when someone who has particular value violates a rule versus someone else, and one has one consequence and the other doesn't, that destroys your effort at culture change. And so it is a real commitment. Are we all in, or we're none in? And the way to deal with the protection of reporters is that people understand that the organization does in fact have my back. When we started collecting reports about unprofessional behavior from fellow team members, we got 25 a year 8 years ago. We get 1,000 a year now. And it isn't because people at Vanderbilt are behaving differently. It's because now what has happened? We trust that we're going to deal with this in a fair way. So to me, those are the things that make the difference. So that's a long-winded answer. Christine, what would you add to that?
Sure. In response to Dr. Friedman's question, and kind of circling back to what's been said, psychological safety and trust is a very big part of making this work in culture change, of course. And a couple ways we do that. One, we built our surveys absolutely confidential. You know, it's strictly confidential. Then the thing that we do in distributing results is we let them go through leadership, encouraging them to do and encouraging the two-way communication between leadership and their front lines. And so we build the trust that way. We build the trust that they get to message that, and then the expectation to do that. Built into the survey, which is strictly confidential with the trust built in, is into our leadership evaluation and our teamwork evaluation are elements of psychological safety built into having good leadership and teamwork. We do use the Schanfeld, I believe it's 12 leadership traits that Mayo Clinic published, and we are part of a consortium, so we can also benchmark. So the way Mayo Clinic has done and the way Stanford has adopted, and we are early in the process, is that you give people a couple of years head start of getting their assessment, seeing what's encouraged to this psychological safety and leadership of involving everyone. And then you create a structure that helps to support that in a number of different methods that appeals to people and supports them. And then you can, every leader in the institution can benchmark against the outside. So everyone can, you know, beat the odds, beat the average of the outside. So you don't necessarily have a hierarchy internally that way. So that's one way to do it. So we do have a leadership training structure that we are building to be more robust and to be more disseminated throughout the whole organization and not just for top leadership. So, and we are working on teamwork by starting to build our teamwork assessments, and psychological safety and trust, a big part of that.
Jerry, I have a question for you. You were the one who was wonderful, one of the big advisors on the MAGS task force for recommendations on what to implement during the resilience. And as you said, the full culture takes 3 to 5 years. We only have weeks. So my question to you is, what would be your recommendations that they could people could put into place now that we don't have any money, and it's got to be fairly simple. You know, what do you think, given that the pandemic we don't have 3 to 5 years and our people are hurting. What would you recommend, just the most efficient thing we can do?
So Florence, first thing, I want to answer this question gently and say that I hear you, but I want us not to lose the long-term view. Because if we don't articulate right now the fact that health systems everywhere all need programs to take care of the wellness of team members, we're going to be back here the next time we have a pandemic. So I will answer your question, but first I want to emphasize that I would not settle for less than what we know in the long run will get us to the right place. Number two, the second part of this is one of the reasons I showed the one slide where we interviewed the 100 leaders and asked them, what did you find successful? And they go back to basics. And I will tell you that in any time of stress, all of us need to be reminded of our core values. Why did we go into medicine? What is it we're trying to do? And so as we talk to leaders about what they'd found successful, it is starting every declaration to the team by reminding them what we stand for and why we come to work. And today, this is what we're going to share and ending that comment. And I have increasingly recognized the value of renewed concepts of values. The other issue is, as leaders, and everybody on this call this evening is a leader. Randy's a leader. Randy's going to behave and conduct himself as a professional, even in a circumstance where we can't get adequate gloves or masks or foam or toilet paper or whatever else. It isn't to say that we don't continue to ask for what we need to deliver the care, but it is how we do it. And then again, when we don't have a developed system, as Christine will remind us, I am more likely to boil over, aren't I, Christine? And so the notion is, how do we teach people in the moment to articulate our immediate needs and yet do it in an effective, non-destructive way? And the final issue that I'm going to say that we need to do this of each other, we need to continue to hold each other accountable as fellow professionals. Now, the one thing I have not said tonight, I hate the word provider. I hate the word provider. I hate the word provider. I didn't say that, did I, Christine? Because we're not providers. We are holding ourselves out to society as professionals. And yes, it's really stressful. But if we are, and our data has shown that people have continued to be professionals in the midst, I just want to make it easier on them. But you can't do that on a dime. It takes $1. And our leaders need to know we're going to be knocking on their door every day till we wear them out. And that's what we did at Vanderbilt. And it must have taken 500 conversations.
All right, I have only question I have left is asking Dr. Heaton, it looks like, are the slides for the webinar available after the presentation? I'm sure David can get those distributed to the attendees. And then I think, David, did you want to wrap up here, or did you had one other person?
I want to make sure Dr. Cross joined us and we moved her to the panel, and she's president-elect of the Cobb County Medical Society, and we've done this for several years, and happy to have the joint effort continue. So I'll let Dr. Cross and Dr. Reiser take it.
Hey, this is Brandy Cross, President-elect for Cobb County Medical Society. I just wanted to thank Dr. Hickson, LaCroix, and Olson, because I thought that that was not only a great presentation, but I also wanted to thank all of you guys who spoke up and asked your questions, because I think that was a great question and answer session. And if nobody has anything else, then we'll conclude the meeting.
It's an honor. Thank you.
Thank you. I love Zoom again. Now Georgia and Connecticut are close together.
And Tennessee, don't forget Tennessee.
Oh, and Tennessee.
Thanks to everyone. What a great seminar. I really appreciate all you've done.
Thank you.